I'm going to begin by answering Dr. Naylor's question a little differently. In his question about whether or not Alberta can lead in this, he picked C. I'm picking B. We have the need, we have the expertise, and we have the leadership to accomplish this task. Alberta can and will solve this and lead the country out of the darkness of disintegration and into light. I'd like to build a mental construct with you that involves three elements. The first is that healthcare costs money. Are you all with me? 2, decisions that doctors make affect the delivery of healthcare services. And third, money is scarce in Alberta these days. In the context of that construct, physicians clearly are stewards, meaning responsible for the careful management of resources belonging to another. Now, we usually think in practice that the only thing a doctor should consider in making decisions is the needs of the single patient he's attending to. However, because of scarcity, every such single decision will have an effect on all other patients. Hence, even in the decision for one patient, there is an element of stewardship for all. In order to be an effective steward, several qualities must exist. To be trustworthy, a steward must be trusted. To live within his means, a steward must be able to manage the resources assigned to his care. To manage resources, a steward needs tools, like information. And in order to continue stewardship work over time, a steward must have an ongoing, effective relationship with the resource owner, including an opportunity for both parties to report back and forth about results and considerations. Is there such a relationship between physicians and society, being the owner of the resources and their delegate government? There certainly is such a relationship, and I will describe it in the context of what I refer to as the social contract. Now, I did not invent this term, the social contract. It's been around for hundreds of years, but I would like to talk with you about it in the context of the relationship between physicians and society. So over time, society has granted these things to the medical profession: trust, autonomy, self-regulation through legislation, a monopoly over certain procedures and services, societal status, and rewards. Physicians, for their side, are expected to provide these things, to treat other people with compassion, to be available, to be accountable for their decisions, to act in the public good, and to provide altruistic service. The interesting thing to me about these societal aspects and physician aspects is that they are linked in an inextricable way that I describe as professionalism, and stewardship is a component thereof. Either party in this may alter or vary one of those qualities, but if in so doing, if that's done, there will be an obligatory alteration or variance on the other side or in the other glass. If we diminish autonomy or trust, then there will be an effect on the way physicians provide service. On the flip side, if physicians are less compassionate or less available, there will be a variance on the societal side of the contract. Both parties can act to maintain or augment the contract by paying attention to those qualities that are their responsibility. In the context of that social contract, my concern is not whether physicians should be stewards of healthcare resources, or whether they should be or could be. That answer is given. My concern is more as to how this can be accomplished and when. Now, the answer to when is easy for me, and perhaps it's the surgeon in me, but the answer to when is really yesterday, and if not yesterday, then today. The answer to how is more difficult and is what today is about and what you are about. The profession is ready, always has been in fact, to assume a greater role as stewards in the healthcare system. We're great at talking, and I don't mean to diminish the value of it, but now is the time to continue to talk, but also to take action. I know I've been talking about a construct, what you might even call a dream of the relationship between society and physicians. But again, I know that in Alberta, we have the expertise, we have the need, and we have the leadership to make this relationship of stewardship between physicians and society a reality. It may be just a dream, but I believe in it. Thank you. Now, Mr. Gormley is going to talk about the reality.
And you took the, where's the control? So in dealing with the topic of stewardship, I'm going to take, there's a lot of different approaches, and you've heard some very good ones, some very wise ones, a lot wiser than you're about to hear now. But this morning, so I'm going to take a particular approach, which is around our relationships with government and how that's dealt with stewardship. Look at some of the streams in that, and then what it might say about how to go forward. So that's what I'm going to focus on. And in doing so, I'm going to talk about, there's really been two major elements to that stewardship when we look at the agreements, and I'm talking over a long period of time, really since Medicare started. So when Medicare started, the issue really was that of price, when you got physicians and government together to talk about expenditures and so on. And what we found through that period, though, is that expenditures rose, of course, because of quantity. And then so starting around in the 1970s, and this is true in Alberta and it's true in other provinces, you started what I would call talks that were around global accountability, essentially ways to stay within expenditures or budgets that government had set. And so, especially early on, there were things that were called hard caps, and those essentially were simply balancing off increases in utilization or the quantity of services by trying to correspond that with reductions in prices. Alberta actually kept with that longer than other provinces. It went on for a long time, and we got into actually more sophisticated models, which might be more called managed caps. And those caps they actually shared the risk a little bit. They looked at, tried to assign responsibilities for various factors, and so on. All of these things have limitations, however, and hard caps ran into trouble in all provinces. In fact, were gone from many provinces before they were here. And that has a lot to do with the insensitivity of the cap and the fact that there was no real accountability that could be managed. Simply the price was going down. It was insensitive to the needs of the population, so waiting lists could occur, challenges like that. Those people who were taking the decrease and so on weren't necessarily the same people who were doing the driving and so on. So that disconnect was part of the challenge there. But nonetheless, it was a model, and as I say, we matured it. In around the 2013 period, something interesting happened in Alberta, in which case, in that the cap actually disappeared. And currently, that's what the government, or that's the agreement that we're dealing with. And we're back essentially to the 1970s on that issue. And what the agreement we have now is really much is a price agreement. It's an agreement over how, and it's very sophisticated in that, in terms of how it will be negotiated, how it will be how fees will be set, and there's a whole new mechanism around that and so on. But that currently, in any case right now, that method isn't in play in Alberta, and that's one of the issues. The other mechanism, so there's that kind of global cap type approach. The other method is trying to deal with efficiency and effectiveness within caps, and Alberta's probably led the country in this regard. All provinces have done this to some extent, where the attempt is to get the most out of every dollar spent. And there's just a whole range of things. This slide could go on. Actually, it does. There's about 50 slides here, and I'm going to go through each one in detail. But they'll just touch on a few of them, but there's a whole bunch of stuff under here. All of them are various ways of trying to get the most out of what is being spent. So we've had strategies around guidance and information. Clinical practice guidelines were good. That migrated into something we call towards optimized practice, where that's now being combined with choose wisely and so on. All really attempts to increase the information to providers, but also to patients in some cases, like choose wisely, to try to impact those decision points and lead to more efficiencies. Compensation has been dealt with in a variety of ways. We've had those of you who know all the battles around relativity and the fee guide. It's a complicated fee schedule and how to set those relative fees. There's very extensive projects done over long periods of time. In Alberta, that's now even matured to a commission whereby they actually have a price authority. We have a price authority in Alberta who can make decisions about relative fees. There have been the issues about fee for service and ability to move into those, as was noted earlier, where don't have as much alternative payment plans in this province as others. That's not for lack of at least discussion. And I'll return to that later, but there's been lots of discussion. There's been models around a blended payment mechanism in primary care that's been on the table for some time. And there's been discussions in the academic world and elsewhere about moving these forward. And we even had models of shared savings, and that goes back a long time, around whereby, and it was in the area, in the one area in the agreement was in the drug area, where actually savings, there would be some shared savings in efficiencies in drug. That lasted about a month. When it became public, there was lots of concerns about essentially physicians making money off of those kinds of drug savings and not prescribing. And as I say, I think it was about a month that lasted. And then finally, there have been some innovations in attempts at delivery and so on. So primary care networks have been the best example of that. So these two dimensions, both the global risk and trying to deal with that, and then efficiencies and looking for efficiency and effectiveness within whatever budget is available, have been in play for a long time in Alberta. and have come and gone in various degrees and so on. Recently, as I mentioned, we've been looking at these issues again. So we do have an agreement that goes until 2018 in terms of its financial aspects. It actually continues on. But with the current challenge that our province is facing in terms of the economics, and with the change in government, we were asked whether or not we would give some consideration in terms of how we would try to bring about the integration in care, bring about some of the changes that a number of the speakers have already mentioned. And that led to a Memorandum of Understanding in 2015, where we did agree to come back to the table, even though we had an existing agreement, and have a look at that and see if we could mutually agree to changes, and that's what would be required. We did actually, in fact, reach some understanding on that, although it's not been ratified, largely because, and I'll get into that, because it's still a work in progress, or that would be my way of looking at it. So those discussions, I think they're important to, because I think it's got some lessons in there. So what kind of did work, and where does work still remain? What did work is, and this included Alberta Health, it included Alberta Health Services, we were able to identify priority activities to undertake and to agree between all three parties on that. And that included in the area of incentives and payment. So for example, a principal part there was making a blended payment model for primary care available. In informatics, so performance reports and so on, there was another group on that. And also in the area of appropriateness, so things like Choose Wisely, clinical pathways, and some of the people in the room were involved in this. And we were able to do that. Maybe even more importantly, in some ways, we agreed for a way to pay for it within the existing payment envelope. So reallocation of money. And I think that's important because it's going to be critical. There is no new money, I don't think, or I'm assuming there's still no new money. That's confirmed. And so if we believe innovation is important and integration is important, and this is going to happen, we are going to have to find a way to reallocate within the system, and that applies to all of us. So it applies to the physicians, obviously, but to AHS and to others. And it also, what worked was the relationships. As I mentioned, AMA, AHS, and Alberta Health were there. I think it was a positive exercise in being able to get that work done and so on. The challenge, or the one that still remains with us, is essentially that financial challenge that, and the sustainability issue. So when you go at it from that global perspective, you get into that challenge I mentioned in terms of the accountability is so diffused that really, how is that accountability being dealt with, and how does it relate to and help with care in the system? I think the biggest challenge with hard caps is it really just leaves things as they are. It doesn't lead to the improvements. The challenge coming up from the other direction is savings capture. So, you know, it's great that we would try a number of these initiatives, maybe make advances in terms of the number of test orders and so on. That's not the same thing as savings captured, and it's a little bit like in the hospitals. The fact that you are maybe more effective and reduce your length of stay doesn't mean your hospital budgets will go down. So how does one deal with that? So looking at these together, and this is the last one, I think the lessons for us, and they're pretty basic, but I think they go along with what you've heard earlier, and then from our perspective. One, this isn't something we're going to be able to be successful on alone. And by that I mean any of us. All of the players have to be involved in making this happen, and so on. We're also going to have to tie, the challenge is it can't just be about that global risk, and it can't just be about that management underneath. It's how the two work together that's going to matter. So I don't think either risk on a global level or simply pursuing, well, we'll pursue Choose Wisely or something like that. Neither of those on their own will do the trick. And it's about how we make these things work together now that's going to matter. And I think physicians want to and do need to take on more accountability for the system and so on, but they also have to be given the ability to manage in conjunction with others. One of the key parts, and it's been referenced, this may be stated here a little differently, is that alignment of strict strategies throughout the system. So putting in a global risk element without aligning that within the system through various means of payment, and that might mean blended capitation in some cases, it might mean pooling some of the payment and so on. It doesn't make sense unless we align those two things, and I think that's the next part. I've used this term here, shared savings, and I used it because it's the one that's been doing the round here. But we need some internal mechanisms in the system whereby those who take on the hard work, who keep those with chronic conditions in the communities and not always going into the acute care sector and so on, there has to be a way to flow resources to that and reward it in some way. I don't necessarily mean in pocket, but there has to be a way that the resources flow to things that make sense. Things like accountable care organizations in the States, and I agree with the speaker who said we really should be looking more to the States than we have been in terms of how they're trying to deal with that. And we haven't done enough of that. And we haven't, when we look at primary care, we're not looking at their footprint across the entire system and then rewarding those who are actually managing it the best. And then the last part I would say in Alberta, and maybe it's because of a challenge of, we have had it pretty good this last while. I've enjoyed it. But it has been, there has been quite a bit of money. It's allowed us to experiment a lot and maybe almost too much. We are great about setting up committees. We are great about new projects. We really have to develop the ability to focus, to determine that, the reality is any 5 we pick, or whatever the number is, there's a criticism that you didn't do, what about the 500 you didn't do? And that's the source of criticism. And I think we just allow that to get in the way too often. We're going to have to find that ability to focus both then our energies and our resources into making these things happen and to implement. And, we have to get over, I think one of our greatest products is actually committees to do pilot projects and so on. So we have to get over that and find ways where we can all agree on these things. So let's leave it at that. Thank you.
So again, we have some time for a couple of questions now, and then we will be transitioning into a panel discussion before the lunch break. Maybe as people consider questions, I'll ask the table at the front here again, is there any more money, Carl? That's Carl Amrine, the Deputy Minister. So maybe I'll direct a question to the two of you. Are there any lessons learned? I thought the analysis of what worked, what didn't is really, really interesting. There's obviously the parallel negotiations that happen in other provinces. Are there lessons learned from, for example, the very recent discussions in Ontario or other medical association government discussions?
Our perspective, Ontario, probably lessons on what not to do. I think what's my own sense is what's happening in the province now here is the more what we should be focusing on. I must admit, in terms of the issues of some of the big issues of the structural change, I don't know that, in my estimation anyways, that the rest of the country is any further ahead than we are. I suspect a lot of the lessons are either to the south or Western Europe and other places like that.
Okay. Braden Mans.
Hi, Dr. Nohr, Braden Mans, a physician in Calgary and health economist. Just wonder, you mentioned something that physicians, and actually we're taught in medical school that physicians are meant to do everything they can for patients in front of them. You also mentioned that the people in the waiting room are important as well to consider when making that prescribing or deciding on what tests to order for that patient in front of you. Has the AMA thought about how do we move from a situation where we largely think about the patient in front of us? What kind of education, or how would we move physicians to think about the patients that are also sitting out in the waiting room or in somebody else's waiting room?
The solution to that lies in the provision of information to practitioners as to what is happening not only in their practice but in the province generally. It's one of the essential tools that all of us need in order to be good stewards of anything.
Yeah, I think that's a major one, and some of the work that the HQCA is doing in terms of providing performance metrics and so on, I think is critical. And the other one is payment. We have been looking at payment models and working with Alberta Health on that. So I think those are the other key ones. And the last one I would mention is the clinical pathways, and a number of you probably saw the people from New Zealand and what they've done and the discussions about how that might be applied here. So one of the things we've been trying to do is how can we, using the resources available to us now, how can we move that forward? Because I think that integration piece between the community and the acute care sector is a key missing piece. I think we've got a good beginning in the primary care within the community, but that integration piece is key.
Okay, one quick question now, and then we'll go to the panel.
Yeah, Louis Franciscetti, I'm an emerge doc and a preventive medicine doc. And the one thing that I haven't heard, and it's actually rather disappointing, is the assumption that we need to have patience as we move forward. I mean, there's plenty of evidence in the literature that the majority of the diseases we treat don't have to be treated in the first place if they weren't diseases. And not one of the panelists has actually mentioned the social determinants of health, poverty elimination, and other strategies that are very successful in keeping people out of our system. I sometimes say the greatest addicts in Canada are healthcare providers. They're addicted to disease. Like, when are we going to get that kind of discussion onto this agenda, as opposed to assuming that we need to spend in Alberta $18 billion a year? 3 risk factors contribute to 4 major diseases that account for 50% of healthcare costs. 5% of patients account for 67% of all healthcare resources that are spent. I mean, the mayor's task force in this city to eliminate poverty in 1 generation will probably do more for health than all the discussion that comes out of this room. So maybe you can broaden your thinking a little bit and stop assuming that the disease burden that's out there has to be out there.
So very important reminders. Wholeheartedly endorse the comment, and certainly I would say, just to make one comment, in the focus that's here on physician expenditures, healthcare system expenditures, because that's what we're discussing. Many people talk about healthcare being the monster that eats up all budgets and takes funding away from education, housing, all the things that relate to the determinants of health, income inequity. Those are fundamental elements of health. The O'Brien Institute for Public Health has a very broad focus and a tremendous population health faculty that focus on just the things you're talking about. So very important reminders.